सर ब्रॉडकास्ट मैंने स्टार्ट कर दिया, मैं साइड बाय साइड आपका कैमरा, ठीक है? Sir, we have started and there are 66 participants connected now.
Some more are connecting.
Yes.
Number is increasing around. I think that it is going around 100 plus. So should I wait or start the things now?
Sir, you can start.
I think we can start and people will join.
Fair enough, sir. So good morning to all. Everyone smiles in the same language, but it wouldn't be possible without the dentist. You are the creators of healthy and beautiful smiles. You have given a reason to the world to interact each other without saying any word and to capture the best moment of life. So welcome and thank you for joining us for today's webinar on the topic Resuming Dental Practice by NABH Standards. My name is Dr. Abhishek Sharma and I am the moderator of today's session. If you have any question during the session, then please type them into the question box in your GoToWebinar panel. I will bring them up during the session and we will also have a time for the question and answer. So now without any further ado, I would like to introduce our eminent speakers who are going to talk to us about requirement of NABH dental standards, infection control practices, quality management in dentistry, which are more relevant in the current scenario of COVID-19 outbreak. So first of all, I would like to invite our first keynote speaker, Dr. Maheshwa, sir.
Okay, we can.
Hello.
Thank you, Abhishek.
Welcome, sir. Dr. Maheshwa, sir, was awarded with the Padma Shri Award in 2014 for the contribution in the field of dentistry. Besides that, he also received the award, BC Roy Award. At present, he is the Vice Chancellor of Guru Gobind Singh University, New Delhi, and the Professor Emeritus Maulana Azad Institute of Dental Science, New Delhi. He is also the Chairperson of Research Committee of Dental Science at Indian Council of Medical Research Center and the Technical Committee of NABH, Quality Council of India. He is the Honorary Advisor of Armed Force Dental Services, Ministry of Defense, Government of India. So, welcome, sir. Hello, am I audible to you, sir?
Yes.
Hello.
Yes, Abhishek, I can hear you.
Thank you, sir. Our next speaker is Dr. Sangeeta Talwar. She is the Director Principal of Maulana Azad Institute of Dental Science, New Delhi. Welcome, ma'am. Hello, Sangeeta, ma'am.
I think she's around. Probably she, maybe. Yeah.
Right. Our next speaker is Dr. Sunita Gupta. She is the head of the Department of Oral Medicine and Radiology, Maulana Azad Institute of Dental Science, New Delhi. Welcome, Sunita, ma'am.
Thank you so much, Dr. Abhishek.
Right. And the next speaker is Dr. Kumar Rajan. He is the Principal Assessor of NABH and the Technical Advisor of IDA. Welcome, Kumar, sir.
Namaskar, everybody. Thank you, Abhishek. I'm not visible there because of some technical issues, but nevertheless, with everybody, Namaskar again.
Thank you.
So before we start the webinar session, I would like to share a brief description about the NABH Dental Standards. Our first edition of NABH Dental Standards was launched in June 2010, and it is again revised in 2012. Right now, we have received 274 applications for the NABH Dental Accreditation Program. Till date, 97 are accredited by dental setups are accredited by the NABH Accreditation Program. Our standards are divided into two parts, Section A and Section B. Section A is related to the dental hospitals with and without inpatient facilities, and the Section B is related to the dental clinics, which is again categorized into the number of dental chairs, which are 1 to 3, 4 to 8, and 8 to 11. Section A related to the dental hospital. Hello.
Yeah, we can hear you, Dr. Abhishek.
Yeah. So section A related to the dental hospitals is divided into 10 chapters. 5 chapters related to the patient centric and the other one organization centric. These standards having 88 standards and 433 objective elements. In section B, we have dental clinics, which is again divided into 10 chapters, 48 standards, and 183 objective elements. So these are the standards in a nutshell for dental hospitals. The chapters are access assessment and continuity of care. The second chapter is care for patients. The third one is patient rights and education. Fourth one is related to the dental material, instrument and equipment. The fifth one is for infection control. The sixth is continual quality improvement. And seventh is ROI. Our eight chapters related to the facilities management and safety. And the ninth one is related to the human resource management. 10th chapter related to the infection control management system. The same is with dental clinic. To know more about the NABH dental standards, please visit our website nabh.co. So thank you very much. So we will go ahead and take some time for the questions now. So my first question to Mahesh sir. Hello.
Yes.
Sir,
Yes,
how?
Abhishek.
Yeah. So being the first chairperson of Technical Committee of Dental Standards, how NABH standards were developed? We want to know, sir, how NABH dental standards were developed and what were the challenges faced during the preparation of these standards?
Yeah, Abhishek, you know that history is always very fascinating, isn't it? And
Yes,
I want to share that we talked about quality, which was not truly a big thing in healthcare. And quality, actually, we were talking about products and industry, and it's only 90s, when the globalization happened, that we talked about quality in healthcare, and probably it was like opening up of the country, globalization, and what was happening in other parts of the world also was felt in India. And basically at that time, quality focused mainly on two things. One was clinical protocols. What are your SOPs? We heard of these terms for the first time, standard operating procedures. And also we talked about outcomes. What are the outcome indicators? How are you feeling that, how effective and how efficient has been your treatment? So these were basically those standards revolve around two things. And actually that concept paved the way for healthcare accreditation and eventually got NABH established under Quality Council of India. I want to share with you that the medical standards was released somewhere in 2006. And I think Dr. Giridhar Gyani was a CEO that time. And he met me, he visited our Institute of Maulana Azad Institute of Dental Sciences sometime in 2007 or 8. And he was really fascinated, to see a dedicated dental hospital. Probably he had gone to some dental clinics before, and then he invited me. He said, we want to come up with standards for dental hospitals. Basically at that time he only talked about dental hospitals and the dental institutions. It did not, the dental clinics was not talked about much. And then he told me that, why don't you take up this job? And he, kind of appointed me as a technical expert, or whatever you want to call it. And I had some internal committee at the MABH from the Maulana Azad Institute of Dental Science itself, and then started working on it. And so the first and the foremost challenge was, this was a new thing in dentistry, quality assurance and quality improvement, because everybody, whatever we are doing, we are providing the care, has a quality, inherent, ingrained in it. So what is the need of further quality improvement, all that? So it was a new concept, and we had nothing to look forward to. Actually, we had, later on I came to know when the medical standards were founded, they took the standards from US, Canada, and Australia, and they were a 5-member technical committee. But I was not given this idea, and to be very honest, I did not. Those days, it was not. It was not a big thing to Google everything. And what I did, they said, this is a medical standard. We have already notified it. And why don't we start on the similar level, start doing the dental standards also. So the first challenge was identity. People said, who is QCI? What is Quality Council of India has to do with healthcare? And who said, what is NABH? Nobody knew about NABH. And the second challenge was, how do we adapt the medical standards into dental? Because medical was predominantly, inpatient standards. Because in a routine hospital, there are inpatients. So that was another thing. And see, most of the standards, as you just said, that your initial standards had, there were two kind of standards: patient-centered standards and organization-centered standards. And there was a lot of overlapping. Then how could we adapt it to this? So we had to restructure, recast into a dental scenario. So that was a big challenge. Another challenge was the time. They said, come on, we want it fast. We already done it. We want to do it. So he was pressing me. So I remember sometimes I used to carry those medical standards in the flight when I'm traveling, and then I'm just trying to adapt it into dental. And so then another thing was there was no clarity, because there were, in your medical standards, there were a lot of statutory requirements, regulatory requirements, and there was not much of a clarity that for dental procedure, what would be the statutory requirements and regulatory requirement. Another challenge, I think, was the marketing awareness, sensitization. Why do we need these standards? That was another challenge. And then, see, most of these, if you look at the initial standards, which were published in 2010, these were very extensive and complex. And I think, that's why probably they did not take off as well as expected. And they were less clinic oriented and more of a hospital oriented. And that was another challenge. And another thing was a branded assessors. Where do we get the assessors? So I think here again, Maulana Azad Institute of Dental Sciences were key, that some of our faculty, while we were preparing it, they got themselves prepared, and they were initial assessors. And also Maulana Azad Institute of Dental Sciences was used for a training of these assessors, so that you could create the research pool. So that was another thing. And the training was also a big issue. Then I think nobody cared to get these standards approved by CGHS. The medical standards, they were actually approved by CGHS, and any facility which was approved by CGHS they got 15% more fee. So it was an incentive for healthcare centers to go, so the dental never got approved. So it was not, that was another challenge. And you see, I think the two things which really popularized these standards, medical standard I'm talking about, it was, I talked to Dr. Girdhar Gyani, and he told me the two things really changed the scenario. One was that they got it approved from CGHS, and that helped all the private institutions going for it, because they could get 15% more charges. And the second thing is they release an ad in the newspaper that following hospitals in Delhi are NABH accredited. And I think that probably was a triggering factor for a lot of other establishment that we want to also get. Now that was in general establishment of the standards. But I want to also share with you the challenges of these standards when we started doing it at NABH for the first time, because we were the first one. As I told you, these standards got notified in 2011, and in 2010 and 2011, the government of Delhi had an advisory that all hospitals in Delhi should get these NABH accreditation. And in our campus, we have 4 or 5 hospitals. Everybody was called, and they said, "No, get ready." So we started working on it in 2012. We were, as you know, that we had a very small number of faculty. We had just started MDS. They were too busy with clinical duties, very small in number. There was no external support. The challenge was bringing everybody on board, because they said why. There was a lot of resistance also, that it is meant for private because they can charge more. It is how the government institution is going to be. So bringing everybody, faculty, staff, nurses, everybody on board was a big challenge. And another thing was the structural changes we had to do. The PW was brought on board, and so many things had to be done: flooring, dadoing, storing the drugs at the right temperature, hand washing area, hazmat area. I mean, so many things. And then establishment of round the clock control room. Then the protocols had to be established. SOPs were made. They were printed. I think almost 35 booklets were printed. So that was signages were a big issue. BLS training of all the staff, including our outsourced staff, which is Safai Karamchari, guard, which are there only for few months. Everybody had to be trained. So that was the need. Then training from fire, bomb, disaster, from police, all those involved. Fire clearance of the building. Can you imagine that how to get a fire clearance? Nobody. So we had to put fire curtains. We had to put all this compressed water system. All those things, the drills, the preparedness, all those. So there was a big then water testing and testing of the water, of the infection in the clinics, and then medical examination of everybody. That was a big challenge. How to get them, they get the files made, and BMW systems were put in place. In the bargain, we got amalgam separators from America, because we wanted to separate amalgam waste. So all those things. So, ultimately, all these efforts, congratulations to the faculty and the team, small team. So we got it. We got entry level in 2010, and final we got in 2011. So, the one thing that challenge taught us, we were the first to get accreditation, and probably that paved the way to become the best dental institution in the country. From 2011 onwards, we have not looked back, and NIRF has just released the ranking 3-4 days back, and the Maulana Jat still continues to be on the top. So we, for a long time, we took pride that we are the only one who has NABH accreditation. I'm sure now many more institutions have joined. So basically, to sum up, the challenges are equipment, materials, systems, infrastructure, the attitude of HR, continued approach, because it has to be dynamic. You cannot just do it one time and forget about it. Increase costs, and the consensus about standard of care, because the same thing can be treated differently. So consensus and record maintenance, HR support, so many things. All these are some of the standards. But the problem is that the best thing is that in today's time, these standards are like a shield to us. It's like armor of protection, kavach. We say that kavach, which is holding us, because all those infection control, all the system, protection, safety of the patient, safety of the staff, safety of the organization from medical legal case, all that is saving us. And have you seen in the COVID time, maids again, showed the way, paved the way. Of course, you do many errors also, you learn from your mistakes. So again, this NABH came to our rescue. And, I think when you have NABH, so the moral of the story is all the institutions, those of them who like to have NABH standards, it will be, a good potent mechanism to ward off the virus, ward off the pandemic, which we are facing at the time, and saving our patients, saving ourselves, and saving our organization. Okay.
Thank you very much, sir. Sir, thank you for sharing your experience with us, and also that the NABH standards are very much effective during this COVID era, and it helps a lot for the Maulana Azad and other institutions. Thank you. My next question
Abhishek?
to Dr. Sangeeta Talwar, ma'am.
Abhishek?
Hello. Yeah.
Hello, Abhishek.
Hello.
Yeah, this is Dr. Atul Kochar. I'm joining as a panelist. Sir, Dr. Mahesh Verma, sir, Dr. Sangeeta Madam, Dr. Sunita Madam, I think this is a wonderful day for NABH that people of your stature and inspiration actually could join us for this brief webinar. And Dr. Mahesh Verma, sir, what you just outlined, the entire history and the journey of maids towards NABH will give so much credibility to all our dental organizations across India. Actually, this is the basis, this was the basis of this webinar, to inspire people to join in and to highlight the relevance of quality even in the time of crisis which we are facing. And you very rightly said that this is the shield actually. So this is the shield, the culture of quality, the culture of SOPs, the culture of checklists, and culture of uniform care, whether it's patient centric or whether it is organization centric, which will go a long way in protecting us from all such crises. So thank you so much, sir, that people of your stature could join us. And this is just in addition to the welcome given by Abhishek. So before you delve into how to unlock and how to go forward, so this was just my brief welcome, official welcome on behalf of NABH. Thank you so much once again to all of you. Please carry on, Abhishek.
Thank you, Dr.
Thank you,
Atul.
Professor Kochar.
So my next question to Dr. Sangeeta Talwar, ma'am. Welcome, ma'am. Hello.
Thank you so much. Yeah,
Yeah,
I can hear you.
Ma'am, MAIDS is the first NABH dental college. So what are the changes you have been observed after having NABH accreditation? Hello.
Yeah. Yes. So
My question to you, ma'am.
MAIDS. Yeah, I heard. I would like to begin this way, that MAIDS was awarded NABH accreditation about 10 years ago. But I would like to say that the process did not end there. In fact, it was the beginning of an ongoing process. During that period, multiple hospital committees were made, like Hospital Safety Committee, Infection Control, Biomedical Waste, Employees Safety, Medical Emergency, Medical Record, to name a few. And during this process, regular meetings, updates, reassessments, reevaluations, action taken reports, and future plans were developed. And it really led to involvement and ownership of every individual of this institute at that point of time. So that was a big thing. Everybody got involved at every level of strata. All employees, including staff, faculty. Majorly infection control program, it led to development of some indicators which are still useful. Actually, they are they really help us a lot during this pandemic situation which is there. And some general infection control indicators were developed, which had at that time included hand hygiene. So as we know today, COVID-19, this is three things we have to remember as of today. And one of them is the sanitization, the hand hygiene. So we have, the institute has already been into this since last decade. So to adapt to the change today, it was really not uh, difficult at all, because everybody is used to doing that procedure. And some specific departmental quality indicators were also developed, and they were specific to every specialty in the institute. And this resulted in what was the advantage that quantification of the quality measures could be done. For example, as an endodontist, you make a lot of instruments within a root canal, doing root canal treatment. So the number of fractures occurring in a month, say, we did not know earlier on. So that we could calculate that 10, 20 fractures of instruments are happening actually. So that helped us to develop plans how to reduce the number of this problem, and also helped us to develop skills in this area. Then came the health of employees. Every year we have a general checkup, and that includes a medical checkup, and vaccinations are also done, and water testing, that is also a part of that. Water testing is done, and post exposure prophylaxis is also undertaken in case there's some for example, needle stick injury. Now this helped us in increasing the awareness, individual awareness about their health situation individually. Everybody started taking treatment for whatever you always tend to not pay attention to your own health. You're working in an organization, you forget about yourself. But this awareness was brought in, and everybody became aware that they have to take care of their own health. Then emergency management. Regular trainings at periodic intervals are still undertaken. This, I said, it is an ongoing process. And code blue for medical emergency, that is well established in the institute. Then for disaster management, we know Delhi is experiencing a lot of earthquakes in the last 2 months. The institute is trained to evacuate this building as soon as this call is given. Everybody is trained for this purpose. Then fire safety measures. All of us, everyone knows how to handle at least fire extinguisher, apart from dentistry, which is being done. Then infrastructural safety. Two, three examples I'll give you. We have a control room where we have the public address system. That is the nerve center of this institute. Anything you want to announce can be immediately done. It is heard all over the institute at that point of time. And PWD, Public Works Department, we worked in close conjunction with the Public Works Department for infrastructural safety of the institute. For example, for differently able people, some washrooms were identified, and handle bars or grab bars. These are the basic things which need to be there. They were installed, and in pediatric dentistry, for example, some electrical points or some plug points, they needed to be out of reach from the young patients reporting there. So that had to be taken care of. And some steel bars were put at open-ended, at the open ends of the staircases to prevent fall of a patient. So to summarize, I can say the positive changes that happened after NABH accreditation would be in three major areas. One related to the patient, that is improvement of quality of care happened, safety and infection control, that is the basic. Then as far as the hospital employees are concerned, the efficiency, the accountability, the skill, the safety, health, everything improved. The bar was raised in these areas. And as far as the hospital is concerned, improvement in hospital processes and several systems were standardized, improvement in quality of care, and infrastructure to deal with any emergency and disaster handling. That happened in the last 10 years.
Yes, ma'am. Thank you for sharing the information about the indicators that you are implementing in your dental institution. Besides that, you are concerned about the regular health checkup of your employees. And what I have just understood that you're also just regularly doing a water testing, which is very important in dentistry, especially in dental colleges and in the clinic. And I remember one incident, about the Maulana Azad Institute of Dental Science in 2014 when I joined this, NABH. So we have gone for the assessment for Maulana Azad Institute of Dental Science, and there what we have observed that they are so much proactive. They are so much concerned about the water testing. They have regularly cleaning the water tank. They are just regularly cleaning the water pipeline in the dental chairs. So which is very important. What I have just understood that this point is very valid, and it should be followed by each and every dental institution and clinic as well. So thank you, ma'am. Thanks.
Thank you.
So my next question to Dr. Sunita Gupta, ma'am. Ma'am, you are in the your department is just like a first line of defense for dental hospitals. So what are the precautionary measurements are taken to avoid cross infection while transferring the patient to other dental departments, and how the screening and the assessment of patients done? Please.
Yeah, Abhishek. Thank you for the question, though. I know it's a very challenging time for all of us, be it any kind of infections. And there was a time when we had SARS, we had MERS, and then now we have SARS, COVID-19, for example. When it was SARS, when it was MERS, we knew that the patient who is infected with SARS or MERS will transmit that disease to the next person who comes in contact. The challenge in case of the COVID-19 or SARS-CoV-19 is it's the same family, which has been, which is where this infection is, transmitting as a zoonotic infection that we're calling it across, wherein WHO declared as an outbreak, and then now it says it's a global pandemic affecting more than 225 countries all over. We do not know who's a pre-symptomatic, who's asymptomatic, or who's an infected carrier for this virus. So this respiratory virus has opened doors to many, many things, and that's when having an NABH accreditation really helps to mask many things as a cross infection, as you had rightly posed this question across. As a dentist, it becomes really challenging, because we know that the oral cavity is the entrance and the outlet of the body. And this saliva, it plays a role in early detection for many disorders, right? And even in case of COVID-19 now, it is one of the, where we take the deep throat swab, for example, nasopharyngeal swabs. Again, the saliva comes as one of the diagnostic aspects to it. I'm just giving you this brief because we need to understand that what are the challenges and why we should be concerned about it. Saliva becomes a vehicle as a source of close contact transmission, for infectious diseases, whether be it tuberculosis, be it any other kind of, viral infections, for example. So now these droplets of saliva, it can travel, long and far along airflow, which is largely determined by the size of the saliva. Now, you'll be surprised to know that, there are about 3,000 saliva droplets that are generated by one cough, for example. Meaning, if you're talking to a patient for 5 minutes, this is equivalent to almost 3,000 saliva droplets. With one cough, there is almost 40,000 salivary droplets are reached to several meters across. And of course, we exhale, we inhale, and again, it generates lots of salivary droplets. When we talk about this the traveling, the droplets of the saliva which can travel across, and it can communicate the respiratory infections which can be transmitted by these large salivary droplets. For example, if the size is more than 60 micrometers, it just drops down, and the person who's in the vicinity, which is less than 1 meter, is the most susceptible, person or the healthcare worker which gets infected with it. The short rate transmission is that when this salivary droplet, which is less than 60 micrometers, in that case, it goes to almost like more than 1.5 meters. And again, it has its potential for transmission. Small droplets, for example, when they're generated, what it does is, because saliva has 99% water in it. Now, these small droplets which are generated, which are less than 10 micrometers, they evaporate in the air, they dry, and then they have a potential for a long distance aerosol transmission. And that is very scary, because if you're not being properly protected, these are the ones which are easily, we can inhale them, they can go through your eye. There is an outlet, is one of the susceptible areas where it can really transmit across. We've been talking about the ACE2 inhibitors or ACE2 receptors for which this virus has an affinity to really join across. Saliva is the richest source to this. Along with that, the tongue, where we have the furin enzyme, which has been talked across. And these two are the enzyme, and this receptor is a kind of a food for this virus. So that's when this, we need to really, we say that the patient has an altered taste sensation, has an altered smell sensation, for example. Now, the aerosols are the suspensions of particles which can range from 0.001 to 100 micrometers, for example. And so it can, theoretically, if you see that it can directly invade to any of these, in any of the person who's around. So now when we're talking about the importance of the screening or the dental triaging, what we have done in our institute, we have a separate space where a location where we are doing the dental screening and the dental triaging. It's not possible to treat all the patients, but we need to understand that we need to start living with this virus now. We need to train our staff. We need to put the protocols in. We need to tell them what is the need of having the safety precautions at every point of time, be it, whether you feel that the patient is asymptomatic, non-asymptomatic, or whatever the condition is of the patient. So training is important. We have the cleaning protocols in place. We have the safety precautions. We have the maintenance of the equipments, which has to be done, again, is very important aspect of it. So when these patients, they're reporting to us, we do a thermal scanning for these patients. At the same time, doing the hand hygiene, we ensure that these patients are wearing masks at all the time. We take a declaration form, what is as per the WHO protocol or as per the Ministry of Health and Family Welfare, the questionnaire regarding the fever and the other things. We are very careful in noting down their addresses, for example. The moment there is any kind of inkling that this patient could be one of the carriers or is an infected for COVID-19, we immediately refer them for the fever clinic or ask them to go for the screening part of it. The screening is done, we ask them the chief complaints. This is done because to shorten the contact of the patient at every point of time with the dental healthcare delivery provider, which is there with us. So in that case, the screening is done, and we assess it out that whether, how much we can delay the treatment for these patients after the chief complaints with the comorbid conditions, for example. So urgent and the emergent cases are only being taken into consideration. And then we refer them to the dental triage, which is also there in the same building itself. What we have ensured in the pre-screening is the distance is maintained. We have put a glass barrier between the staff and the patient, which is almost 1.5 meters distance has been maintained across. And at the same time, it's well ventilated. There's a illuminated, well ventilated, and we ensure that if the patient needs some kind of medication, takes it from there, and at any point of time just leaves from that particular place. dental triaging is done, and based on it, whether the patient if has trauma, if has some bleeding disorders, acute pulpitis, for example, which can't be delayed across, and those are the only cases that we are referring it across to the for the treatment aspect of it. So this is how we are trying to reduce the load. But I think in the private setups, what is required is that we have the provision that we can do. We, instead of the walk-in patients, always have the appointed cases in place. Make a telephone call when the patient asks them that they can only come with the prior appointments. For example, you can do the tele-screening for them, which is telephonically done. You can do a tele-dental triaging for them to understand what is the preparation you need before the patient really gets in. They should not be getting their baggages across. They should not be trying to avoid using the toilet, the restrooms and the toilets in the dental operatory or in the dental clinics, for example. It's a very important aspect. Patient relatives should not be allowed inside because they'll be unnecessarily doing a lot of waiting area. It'll be all commuted across, and appoint as a single patient at a given point of time, for example. When the patient, of course, is entering, you can always give a head cap to them, or maybe use the dental shoe covers and so forth. So as we do it, they should be wearing their complete personal protective equipments so that the transmission, they're confident. And must remember, if you have a personal protective equipments and the devices with you, will be confident in doing so. And if you do not have, just do not venture in opening out your dental setups. Because this is something which, it's not that we are preventing the cross infections or we are ourselves saving, but we are also at the same time being responsible from transmission from our side even to the patient at the same time. So this is how we have really undertaken it out.
Thank you, ma'am. Thank you for sharing the information regarding. Actually, I don't know about that 3,000 saliva droplet, spread during the discussion or conversation with the patient, within 5 minutes. So really, it's a very wonderful information, and the patient tries it is more relevant in this COVID time. So in our college time, what we have, we were doing all the precautionary measurement while doing the patients as a dentist. So I think that it is very relevant nowadays. Thank you, ma'am. Thank you. So
Thank you.
now my next question to Dr. Kumar Rajan, sir. Hello.
Hello.
Sir, can you hear me?
Yeah, I can hear you, Abhishek.
So, sir, my question to you, sir, everybody is concerned about the air droplet. As a dental surgeon, we use air rotor in our dental offices, which is the main cause of air droplet, water droplet. So my question is, what are the cost-effective engineering controls which may minimize the spread of aerosol while performing AGPS?
Okay, thanks for the question, Abhishek. Engineering controls as regards to the NABH standards are very important. And if all the accredited institutions as well as the clinics, if they go through the standards and the objective elements mentioned in the standards for dental healthcare service providers, they will find that there is a mention of engineering controls, how we can better from each time, one step at a time, but it should be better than the last time. Now, when you talk about the engineering controls, it ranges and it needs to be, it ranges widely and it needs to be cost effective. Now, when you talk about the larger institutions, I think the esteemed panelists from Maulana Azad, they will be able to deliver on that. As regards to the clinic, if you say there are few small things which can be done at the clinic level, which is very cost effective and important. For example, we need to put, if you see the design of the clinic in many areas, you'll find that in many metropolitan cities, the clinics are surrounded by walls from all the 3 sides, and there will be many situations when the opening will be only from one side. It becomes very much a problem that there is no air change in those facilities. So it's important that the air changes be done. And I would encourage most to kindly go through one guideline which has been issued by our government of India, which is National Guideline for Infection Prevention and Control. Though it largely talks about the general measures, it gives a guidance in table 5.2 as regards to the minimum air change per hour for various healthcare settings. And in that, it suggests that the outpatient departments and waiting areas, it should be, the air change should at least be more than 6 air change per hour, right? Now, when you do that, air change, first you need to know how much big is your operatory. So that can be calculated by the length into the breadth into the height of that particular operatory. So for example, if length is 10 feet, width is 10 feet, and height is 10 feet, it becomes 1000 cubic feet. Now you need to, a simple measure could be to put an exhaust fan in a direction where it is appropriate and where it can be, placed. There are few clinics in which there would be window. You can, if at all major renovation is not possible, at least in the times of COVID, especially when as madam has said, aerosols play a major role. It is very important that you place the exhaust system in the window pane, and after calculating how much is your cubic feet area, you need to accordingly put the same level of exhaust fan. It is also important, many a times I see that in the clinics, ceiling fans are working. Ma'am would agree with me, Dr. Sunita madam would agree with me that if at all there are dental chairs which are placed side by side, ideally at least there should be a gap of 6 feet in between. But if they are placed side by side, parallel to each other, and there are ceiling fans working, that there are much chances that the aerosol will travel from one chair to the other one. So now it is very, very important that all the setups wherein these kind of arrangements are there, at least they should, put the patient on, say, for example, chair 1, then 3, because then it will increase by 12 feet at least. But even if when you switch on the fan, the aerosols will be all over the place. So that's why it's very, very important that the flow should be designed. When you design your clinic, or when you kind of renovate it, or when you have the chance to do it, please have it designed in a way that the air comes from one side and leaves from the other side. So that's one cost-effective engineering control that can be done. Now, that's regarding the environment. Now, for example, if there is absolutely no space available for exhaust to be put, then in that case, the purifiers, which are at least having HEPA 14 grade filters, can be placed there. And if now the air through that can be then changed, which will minimize the aerosol as well as dust and infection, but it will not completely eliminate, right? So these are the two things for the environmental changes. Now coming to what we can do as an engineering control when you are treating a patient. So we all know that dentistry, most of the procedures are aerosol generating procedures, and our life is dependent on them. Aerosol is our best enemy, at the same time a friend also, because our life depends on that. So you can do a minor change. Most of us in many practices where I have been or otherwise, we are used to of treating the patient with the saliva ejectors. Now there are two, please remember this is very important, that there are two suction systems provided in the clinic, in the chair, in one chair. One is called as low volume suction, and that is called as saliva ejector. And the second is high volume suction, right? It is very important that when you are trying to minimize the aerosol, you please use both of them intraorally, right? Train your staff to do that, because unless and until there will be a scarcity of the space, because already if you are putting two of them, it's going to give you a problem. But at the same time, if aerosol have to be taken out from, say intraorally, then the point from where it is being generated is where you need to attack, and there the high volume saliva. So the dentists, they must check their chair, and they must check their suction system. Many a times I have found that the dental chair would have a pneumatic suction. Now pneumatic suction will not give you the advantage of even a high volume suction. Pneumatic suction just gives you advantage of a saliva ejector, because it is directly connected to the compressor, and not the suction. So it's very important in this time that you need to have a proper suction, and that proper suction machine should be, able to take care of the high volume as well as the low volume. And secondly, there is also an extra oral suction which can be fit into that particular system only. There is no need to buy expensive machines. There is no need to buy, many technically, very, very, very expensive machines. You have a funnel. You have a funnel. We all have used a funnel somewhere in our childhood or otherwise. So that funnel, which is having a wider diameter, say of at least 8 centimeter to 10 centimeter, can be fixed into the high volume suction tube, and that can be placed near the chin. So after the intraoral suctions of, both of the intraoral suctions have been used, the low volume and the high volume, anything which is coming out of the oral cavity, be it droplet nuclei, be it droplet, be it spatter, or be it aerosol, most will be, collected there only, and it will be taken out through the suction system. So this is very, very important as a cost-effective method. You don't have to spend a lot on this. The third thing in terms of the engineering control which comes to my mind is the cleaning of the high-risk areas. Please make sure that once you have used the suction appropriately in the patients, please make sure that you have disinfected it well also. Most of the time, if the disinfection is not done and then it is not taken out, as Maulana Azad Institute of Dental Sciences would be the premier institution which has, even taken care of the fluid which is coming out, and it treats the fluid also. It's a commendable thing to do. It's a very expensive thing to do as well. So I would request that for the clinic, the smaller clinics, you need to use a kind of small equipment. For example, you can use a Orotol cup. Now this cup has two nozzles in it. One nozzle kind of takes care of the low volume saliva ejector, and the other one takes care of the high volume saliva. Now you just put those nozzles there and then run the suction machine. The disinfectant is now passing through the tubings into the suction system, and from suction system now it is coming to the pit wherein it is treated with the sodium hypochlorite, and now then it is discharged into the environment. So again, there is not much cost involved, but the same thing can be done. So these are the three practical suggestions I would like to give. Thank you so much. Over to you.
Thank you very much, sir, for sharing such cost-effective measurement, especially in dental setup, by which we can reduce the results. Because generally, maximum number of procedures we do with the air rotors, and then in that air rotors, water droplets are very common. So I think that these methods will definitely help you, the dental surgeons. Thank you, sir. Thank you. So my next question to Dr. Maheshwa, sir, again. Sir, my question is, why dental insurance coverage is important, especially in developing countries like India?
Thank you, Abhishek. It's a wishful thinking, and we've been talking about it for a long time, and we are still awaiting the result. But why, you ask me, why is it important? I think the first and foremost, a sweet and a short answer to this question is that this is the only way where we can make the oral care affordable for everybody. You know that our dental treatments are hugely expensive. I have seen even the wealthiest persons will go to a hospital, stand in a queue, wait for months together to get the treatment because they find it expensive. And also we have a mindset that healthcare has to be free, isn't it? And when healthcare involves dental care, you know how much And also the second thing is that healthcare is fine, but dental care is so much need-based, because the dental disease is so much prevalent. Almost everybody, including some of the panel, also having dental problem, isn't it? Everybody's having it. So, and these are preventable. So there can be, when you have insurance, there's a likelihood of a lot of people getting the treatment. You see how insurance company plays. He plays that out of 10, 1% will get the treatment and 9 will be healthy. But here, everybody is likely to get treatment. So the premium has to be very high. And another thing, the cost of the complications of dental care is also very high. Suppose you don't treat a tooth, you don't get RCT, you have abscess, you have a cellulitis, you have osteomyelitis, all those things. So see, the cost of complication is also, so this is one reason. I want to share I read somewhere that there was a survey done recently, and where people were asked, would you like to subscribe to dental insurance? And 90% of people said yes. We would only go for a checkup. We will go for a preventive treatment, provided there's a dental insurance. 90% of the patients who were already going to dental clinics, and they were surveyed, and they said they are ready to take a dental insurance because they know it is very expensive. The dental treatment is expensive. They realize and they think that maybe they are able to offset some of these expenses via dental insurances. And also, if you look at people have heard of Mediclaim and all those things, health and insurance, but nobody knows about any dental insurance. Probably one reason is that because it is not available, the product is not available in a country. So, I feel that when you have a dental insurance, and it's coming, I will talk to you about that. So when a dental insurance, like it is in a Western country, they know that they have to eventually go to a dentist and they have to pay a lot of money. So they are prepared for it. So, when you have a dental insurance, there will be more of awareness. The patient will be more motivated to go for a dental care, especially regular visits. Why the neglect happens? Because we don't go. Why we don't go? Because it's not life-threatening. Why we don't go? Because it costs money. Why do you go? We think it's okay. After all, it's only a tooth. I can get it extracted. All those. See that lackadaisical approach to the dental maladies is the reason. So when we have insurance, there'll be more focus on a primary care, secondary care, rather less of tertiary care, isn't it? Because we will be more motivated, and anyway we think it's a free, we're paying for it. So let's utilize it, isn't it? So also there'll be more of early restorations rather than that approach that okay, let it go, it doesn't matter. And also I think the patient will also be able to explore a better treatment option. Suppose your tooth loss is there, if your insurance is covering it, you will go for a bridge or an implant. Implant, of course, no insurance will cover. Or at least you'll go for a bridge or something. Otherwise, you'll go for a flip. You'll go for a denture. So the better treatment modality, isn't it? So the present scenario is that we have a large number of medical insurances, but most of them only cover dental, either OPD, and also to a very limited extent, say 1% of the coverage or something. And also why? Because they know that these treatments are discretionary. Because see, in healthcare, treatments are not discretionary. It's an urgency. It's an it's impacting your life, quality of life. So the cost of the treatment is also varying. You want to get it done here, and you want to get it in Moradabad, and you want to get it done in Himachal Pradesh. There is no standardization. There is no standardization of clinic, standardization of care. There is no consensus of the care. If your problem is there, somebody says I can correct it by pulpotomy. Sangeeta will say I will get it done pulpectomy. Somebody say I will do apicectomy. All that. There's no consensus. So that's another thing. And most of the present medical insurances, which is covering dental care, requires hospitalization or accident. Then they will probably be able to cover that. So it's still a very nascent stage, dental insurance in India, but there's a huge scope. And basically there are two kinds of insurances. One is the standalone insurance for dental care. Like nowadays, you must have heard that the companies are coming up with COVID cover for your family, for your staff, for organization, only COVID. because your routine medical care insurance is not covering COVID, you know. So there can be a standalone dental insurance, or it is, you know, it is piggy riding or piggy backing on a medical cover, and with certain riders or certain restrictions that, okay, you can get a dental treatment also. I feel that other reason is that the role of NABH comes here. Why are you asking me this? Because NABH standardize the clinics, and also when the dental insurances come, they will enroll clinics like HMO or PPO. There are two ways of doing insurances. Is that they will look for clinics first which are NABH accredited. So big huge role of NABH standardization in getting the insurance company. So also more of our care is urban centric, town centric, and less of rural centric, and most emergencies can be handled just by a tooth removal. So all these things are there. That but the thing is that if all these things to be covered in a medical insurance, then probably the premium will shoot up many more, much manifold. So again, it will become unaffordable. So it will be a boon, and because it will bring about awareness, bring about motivation, bring about less indenturism. Today we are talking of immunity. If there are no teeth, what is immunity? He is not able to eat, isn't it? So there will be less of tooth loss, more of restoration, more of preservation because of this. So today we are only having fee for service, isn't it? I want to share with you that we have some a couple of companies which are covering dental, but very differently. You know, most of the companies which are having medical like Apollo, Bajaj, Bharti, Birla, New India, you know, all these ICIC, Chola, all these companies, either they are unit linked, that means you save some money and use that money for any care, yeah, that including dental. But most of them require either hospitalization or an accident. So if you had some problem, if you had an accident and then because of that you needed a dental treatment, so that is one. Now the good thing is that it's in pipeline, and some of the companies like ICI Prudential, Bajaj Alliance and Star Alliance, they already have formed a standalone dental insurances, and it's lying with IDA, you know, that the authority which regulates all these insurances, and they will, you know, as per information, I gathered some information, the cover will be costing something like 2,000 to 3,000 rupees per person per year, but it will not include any ortho treatment, no implant, no cosmetic, no veneers, no laminates. And you know that in India, a lot of malpractices also happen. I want to share with you two examples. In Chhattisgarh, they said 2,500 per family for 5 members. You know, in 4 months they had to stop it. The government announced, because people started sending bills. I did this, I did this, I did. You know how we know how do we circumvent the systems, and something similar happened in Orissa also. So the government had to withdraw. So because also when these insurances come, depending upon the cover, your co-payments also will be more, like 5%, 10%, 15%. That means the amount, even if it is insurance, you have to pay from your pocket. So all this is there, and eventually I think it is a, as you said, it's a wishful thinking. It will increase patient to the clinics. It will bring also more accreditation of the clinics, and I think it will be good for NABH, and I think the public affordability of the dental care will also increase. I want to share with you, at the moment only 7 to 8% of our population is getting health insurance. Even it may be even less. So initially when dental insurance comes, only these people who are used to insurances will probably go for insurances. But I think if the premiums are less, and if cover is effective, I think more and more people take. And also we can expose whether the government can also take some of the poor people, especially with BPL and all those things. Like we have this PMJ, Pradhan Mantri Jan Ayogya, the scheme PMJ, which is looking after almost 50 crore population, almost 11 crore families, for poor people. But again, there cosmetic is not allowed, All these things are not allowed. It needs hospitalization. So if it is dental, if it is hospitalized, it can be done. So I think things will open up, and this is need of the hour, and this is also good for NABH. People will get a lot of standardization of their clinics. Thank you.
Thank you, sir. Thank you for sharing the information regarding dental insurance. It's a surprise to know that 7 to 8% population insured for the dental procedures. Sir, I would also like to know about one thing, that's how technology will be effective for standardization the process. Do you think that technology will play an effective role for the uniformity of dental procedure?
Yeah, I think technology has already played a role. There's we have really turned around the way we practice dentistry with technology. Now it is only the technology which is allowing us that least contact with patient, doing things virtually. There's so many. We are using technology at every step today. So technology not only be a boon to improve the care and ultimately enhancing the quality, patient satisfaction, treatment which are predictable, safer, simpler, long-lasting, and less costly. It's only technology can do that. We are using smart materials and smart technologies because we are looking for treatments which are predictable, simple, safer, long-lasting, and faster. So only that can do it, and also predictable. When you say predictable, with the same quality standards now, whenever you do it, isn't it? So I think it's only technology can do that. Thank you.
Thank you, sir. Thank you very much, sir. My next question again to Dr. Sangeeta Talwar, ma'am.
Yes, please.
Ma'am, do you think that NABH standards are effective and helpful for the management of any infectious disease outbreaks? Hello?
Yes, yes. Can you hear me?
Yeah, I can hear you, ma'am. Can I repeat the question, ma'am? Hello?
Yeah,
Please.
I can hear you.
Yeah, ma'am, my question is that do you think that NABH standards are effective and helpful for the management of any infectious disease outbreaks?
Yes, I surely believe this. Believe with this. Definitely, the answer is yes. Infection control policy, according to NABH standards, we have spoken so much till now, and they are most helpful for management of these infectious disease outbreaks. We can see in the current scenario what is happening. Basic infection control depends on, all of us know, on 5 premises. First is air ventilation and management. One of our speakers spoke about the airflow, the number of airflows required in the clinic, depending on the area of the clinic or your operatory. Then second, this is A to E. Then B is the barrier protection. This is the PPE. In this today's times, with we have been speaking about the aerosol generation. PPE is complete PPE. We have everybody should be aware what is a PPE and what are the components of a PPE. So that is very important. It will consist of your overalls, then your N95 masks, which are most prevalent, most suitable in today's times. Then you have your eye protection, then the face shield, then your head cover, gloves, and of course your foot covers. So that constitutes complete PPE, which all of us must wear and practice. Then we come to the clinical protocols, followed by disinfection protocols. In disinfection protocols, with a little tweaking in the set standards in today's times, it is not advisable to use the sprays when we are doing disinfection of hard surfaces, and it can be wiped clean. And of course, the most important, which cannot be ignored, is the education. We need to educate ourselves, all our staff, anyone working in our clinics. In fact, the patients also need to be educated regarding the basic protocols, which in today's, as of today, the standard is set by the policy, infection control policy. But tweaking that, I'm again repeating, there are three things which we need to do. One is the social distancing. Then we have hand sanitization and thermal scanning, and of course the masks. So I would say in this context, commitment is extremely important for us to be successful. You have any mechanism set in place, even if it is a perfect mechanism, you don't have commitment in whosoever is working with you or for you, then it may lead to failure. So what basic thing is that commitment in ourselves, it should be there for us to be successful, for any mechanism to be successful. Yes, please.
Ma'am, do you have any protocols for for any kind of outbreaks, for any infectious disease outbreak in your hospital?
Yeah, I mentioned we already have our infection control guidelines in position, so it was not very difficult for us to switch over to the outbreak of COVID-19 that happened in March. And as Dr. Sunita Gupta has spoken, we have been practicing with the little innovations in the triaging area, reporting area, the registration, the dental triaging, pre-screening initially, and the distancing, social distancing, that is how the patients stand in queue is extremely important. They are not to, you have to ensure that proper distance is maintained amongst the patients also.
Thank you, ma'am. Thank you for sharing that NABH standards are very much effective in for the management of these kind of outbreak, and you are practicing a good infection control in your hospital. Thank you, ma'am. My next question to Dr. Sunita Gupta, ma'am.
Yeah.
Ma'am, in India, around 19% dental setups are having 1 to 3 dental chairs without OPG and CBCT facilities.
Yeah.
So my question is that what are the protocols should be followed by the dental surgeons to avoid or minimize the infection while taking intraoral periapical dental medicine?
Yeah, a very relevant question because, what Dr. Rajan was mentioning in terms of what Dr. Sangeeta mentioned about the infection control protocols to be followed, for example. And for every treatment modality, it's the radiograph which comes as a backbone again, because most of the treatment plans depends upon the radiographs. There are challenges when we do not have the extraoral radiography, procedures, or the CBCTs or dental panoramic radiographs with us. It's must remember that, Savdhani hati, durghatna ghati, which is like, we say as a standard, whether we are driving or whether we are in the railway station. So we need to be careful to ourselves. That's the first thing. Just tie a knot to yourself that this is what has to be followed. Having said that, meaning that the operator who's going to use the IUP X-ray machine or the intraoral periapical, it's advisable that we use RVGs or digital sensors, for example, so that it's faster. We do not come in contact for a very long time. Now here the problem lies is that the patient is going to, there's a possibility he's going to cough, there's a possibility he's going to gag, and with this, the moment you put any foreign thing in the mouth, there's a stimulation of salivary flow which is going to happen. So in such circumstances, one, that we should have the operatory, as Dr. Rajan mentioned, to have an exhaust, uniflow direction of the, the air and so forth, not having the fans on, the AC, centralized air conditioners not being on. We need to have the digital system when we are using it. We need to have a double barrier for sensor. That is how we need to be, preparing. We need to put a cellophane sheet on the cord that the sensor is going to have. At the same time, there should be full PPE while taking the radiographs, whether it is an intraoral, whether it is an extraoral. All the touch areas that the patient is going to use, for example, is that we have to ask the patient to go and wash their hands if possible with the soap, sanitize their hands. That is one thing. Second is ask the patient to do a rinse with 0.2% betadine or povidone, or maybe hydrogen peroxide rinses, which is 1% H2O2 rinses. That is the oral. Keep it in the mouth for 30 seconds, spit it off, not to rinse subsequently with normal water, drink water thereafter, and he should come for his radiograph. Now, we have to, if have to have the compliance from the patient, we need to explain to the patient that this is what the procedure we are going to do to you, make the patient comfortable, tell them that, you need to take a deep breathing while doing this, don't get panic across. It's just a matter of some couple of seconds that the radiograph is going to be taken across. So that is how we normally, should follow the protocol, but wear your goggles, wear your face shields, wear your cap, head caps, a complete gown, so that, in case of any adverse, wear your N95 masks. On that, wear a surgical mask as well, what Dr. Sangeeta just mentioned. Once we complete this process, there can be a how to do the imaging films, or if there is a phosphor plate sensors, for example, that we are using it out. So we need to use a no-touch technique, which is like, the operator, he dries the intraoral packet with the tissue and then wipes the packet with a disinfectant, 1% sodium hypochlorite or 70% ethanol or isopropyl is the commonest used. Then the gloved operator, he tears open the protective outer, the intraoral packet, and that the image sensor plate or the packaged film is then dropped onto a clean surface. So the second operator then can transfer the film and the sensor for the processing. So that is a kind of a no contact touch technique that we that can be used. And then the gloved operator, he tears open the protective outer intraoral packet, and once it is placed there, and this is how is being followed across for if you're using in your own operatory or in the dental clinics, right? And while we are doing so, just ensure that if possible, if you have some clinic or a space where you can separate out your radiology aspect of it, would be advisable, so that the aerosols which are generated, as we've been talking across, Dr. Rajan is talking, Dr. Sangeeta is talking, those aerosol productions are not being really into the air for a longer period of time. So this is something, but as far as possible, try to have an extraoral radiographs, and or maybe the digital CBCTs for the small areas you can have. That would be really helpful and useful at the same time. So
thank you for your advice. While taking the X-ray, IOP X-ray during the dental procedure.
Yeah, and I think once it is done, Dr. Abhishek, what is recommended is that all that we remove the cling films from the areas where it has been, for the external radiographs, if it is like digital panoramic, you can always use the surgical mask, which has as a plastic clip, so it doesn't come, so the patient can wear the mask, and then you can adjust it on the chin rest in case if you're suspecting that the patient could be a COVID positive or can be in contact, and you need to have a radiograph for that patient. So we cannot, I mean, it's okay if the patient is wearing a mask and we are taking the radiograph. Otherwise, if the patient is biting across, then we need to be careful that, Once the procedure is completed, we take 1% sodium hypochlorite solution, disinfect the complete area, leave it for 10 to 15 minutes time, and then take the next patient into consideration. Thank you.
Thank you. Thank you very much. So my next question to Dr. Kumarajan, sir. Sir, can you hear me? Hello?
I can hear you. I can hear you,
Yes,
Abhishek.
So my question is, what are the views on biomedical waste in the present context of COVID-19, and how following NABH standards help in a proper handling of the same?
Okay, thank you for
What do
the
you say?
question. Yeah, thank you for the question, Abhishek. I mean, say this is something which is very, very important, biomedical waste management, and thanks to the NABH standards, and I'm sure all the participants who have their clinic accredited with NABH or otherwise are practicing NABH standards, they would kind of connect with me when I say that it's so easy. It becomes so easy to practice BMW waste management if all the standards are being followed and the objective elements as described against the standards are taken into consideration. Dr. Maheshwa already suggested about how much training he had to, undertake for his staff and the Safai Karmacharis to do it. And believe me, it is one area which needs the attention always, as Madam has suggested, Dr. Sunita, Madam, Savdhani Hati, Durghatna Ghati. One thing which is one issue which I would like to raise here and listening to all the 101 attendees as of now is that they should go through the BMW management protocol. 2016 when it was enacted, and after that 2018 it has been amended, and after the amendment again in 2020 it has been amended as per the COVID context. So the larger hospitals or the institutions or the dental colleges, they should be taking the lead, wherein they should be letting their people know, the people who are handling, the staff who are handling the biomedical waste management, know about the proper protocol of the amendments made in 2020. Coming to the private clinics, it is very important that they go through the document properly. The first one, the 2016 one. And it is equally important that they need to have an infection prevention and control manual. You would agree with me, Abhishek, that all the clinics which are to be assessed or otherwise are there, they have an infection prevention and control manual, however small or big that may be. But that's as a policy document. Now, for smaller clinics, it's very important that even if you have a 5-pager, but it is in bilingual and you are able to communicate that important information to your staff, because that is the most important. They are going to deal with it. They are going to make the solutions. They are going to make the disinfectant, if the disinfectants have been made in the proper concentration or not. When I ask, for example, what is 5% concentration of sodium hypochlorite, many a times I don't see that happening properly. So that's why after they have gone through the document, it is the duty of the owner, proprietor, or the chief consultant of the clinic to provide the proper training to the staff. And please record the minutes of the meeting that you have provided, and please take photographs so that next time they can go through that appropriately. Now, the required PP, as Madam Sangeeta was mentioning, the required PP has to be there. And you would be glad to know that there have been 2 advisories coming from 2 guidelines coming from the government as regards to the rational use of personal protective equipment from Ministry of Health and Family Welfare, and one has been revised very shortly. So that has to be done. It also needs to be taken care that people who are handling biomedical waste management needs to be vaccinated properly, at least for 2. One is hepatitis and tetanus, because it's mandatory by the government that it is the duty of the owner to have that done for their staff. And finally, it is important to maintain the record of the waste generated and collection, because when we match the policy and the procedure, when we go to do the assessment, there would be chances that you are generating more PPE. All the panelists, all the August panelists here will agree with me that when you use a gown, when you use a full gown, when you use an overall, when you use other PPEs, the weight increases, right? Now, when you go through the MOU between the vendor and your clinic, you will appreciate that there is a particular kilogram mentioned, that you can generate only this much kilogram per day of waste can be generated. But if they are taking more, then it is again an issue which needs to be sorted out. And in COVID-19 context, I am sure that this is going to be the case, wherein even putting one overall in the bin will fill it completely. So that's why my advice to all is that please have extra bins. Please have extra blue, red, and yellow bins, because you would not be able to keep them appropriately. And if you don't keep them appropriately, then you are spreading the infection rather. So it's very, very important that the donning and doffing has to be done appropriately and as per the required settings. Now coming to the aspect of what goes where. In the red bin in present context, the personal protective equipment like goggles, face shield, splash-proof apron, say plastic coverall or hazmat suit or nitrile gloves, they will go into the red bin, right? Then you talk about the yellow bin. These two are the most used in dentistry, I would say. Then in yellow bin, you will have used mask, triple layer mask and N95 mask, head cap or cover, shoe cover, disposable linen gown, non-plastic or semi-plastic cover. Also, these will go into the yellow. Many a time there is a confusion what will go into which bin, and that's going to be a problem. So that's important. And of course, the white will have this waste sharps, including the metals, needles, syringes, say for example with fixed needles or needles from needle tip cutter, and so on and so forth. And the blue will have the glassware and the metallic body implants, and even the, for example, our fixed bridge, if you are removing a fixed bridge for some reason, it will go into the blue one. So it's important that a proper training should be provided to all the staff taking care of the biomedical waste management in their colleges, in their clinics, and accordingly the space be created so that the infection is not spread, rather it is contained. Thank you so much. Over from my side.
Thank you, sir. Thank you for sharing your information regarding the biomedical waste management. And I believe that the training on biomedical waste management is very important, especially for the dental hospitals and the clinics, so that they will manage the biomedical in a better way. So we have covered all the questions right now, but now we have some questions from the listeners. So I would like to share some questions with our speaker. So Dr. Nair has asked one question to Dr. Maheshwa sir, that is there any teledentistry guideline officially available similar to the telemedicine one? Hello.
Can you, Abhishek, can you come again?
Yes, sir. Sir, Dr. Nair asked one question. Teledentistry, sir.
Teledentistry, I don't think there is any guideline teledentistry. In fact, this teledentistry has been given new lease of life. We've been talking of telemedicine, but thanks to Corona, now this has come big handy, and a lot of us, initially when lockdown was there, even otherwise, they said only emergent treatment to be done, and most of the patients would be disposed of through a telephonic consultation. And not only dentistry, I think even the physicians have used this modus a lot. And there are no guidelines, I don't think, but there were some issues that whether you can charge for it. Certainly you can charge for it. Any consultation can be charged, because that has been a bonus, a point of contention, that whether it is free or no. Oh, certainly, I know a lot of people, they are making you pay and then they will be consulting you, or after that they are supposed to be consulting. So there's no specific guideline, but this is again, there was another issue whether it is valid in a legal court of law, legally. Yes, it is tenable, because you are it's a fee for service. you are taking a fee and you are providing your service, and then it is very well, it has a cognizance of law. Yes.
But in this COVID-19, sir, we have seen that a lot of patients come with the problem of dental pain, which is a kind of emergency. So, do you really think that teledentistry will help you in this way?
No. See, I'll tell you. There are many kinds of pain, dental pain. Of course, if it is pulpitis, of course, patient doesn't understand his pulpitis. But when you take a history, and that can be taken again through telemedicine, teledentistry. You understand what is it, what you have. Sometimes they click a picture and send you, and most of us are doing that. But and sometimes pain can be managed, but if it is pulpitis, it has to be. Then there is no way. It has to be it has to be taken care of. And I know that a lot of our practitioners, this is what is emergent and urgent care, isn't it? So that has to be done. But otherwise, I think it can a lot of things, because people have a lot of doubts in mind. They have fear and anxiety. A lot of our pains and associated fears are also because it's psychosomatic, and many a times we can use, not necessarily that we have to do a operative procedure. We can counsel them. We can speak to them, talk to them, and explain to them. And again, you see, because I want to tell you that even those patients who are coming for a treatment, suppose urgent care or emergent care, they have to be counseled first by telemedicine. They are told what is it, what history do you have fever, do you have pain, have you had cough, have somebody in your family. So all that, so it's a very integral part also in today's time. It's very integral when we are supposed to be following the social distancing. So it is one of the modalities, and of course it has a limitation. Everything cannot be done by consultation, and we all understand that. Thank you.
Thank you, sir. Thank you very much. So I have received another question for Dr. Kumar Rajan, that what are the methods to check in the quality in the dental hospitals? Over to you, Dr. Kumar, sir.
Yeah, come again.
So what are the methods to check the air quality in dental hospitals?
Right. So as regards to checking the air quality, first of all, if you are checking it for the pathogens, then you need to take swabs from different areas. For example, if it is the AC exhaust system, or it is the normal exhaust system, or you can go to those areas where are hard to reach by the air and collect samples from there. If you are collecting samples from there, give it for the culture. If there is any microbial growth, then it is advisable that the proper infection prevention and control things should be done, undertaken, and accordingly it needs to be taken care of.
Thank you. I think that I have covered all the questions, from the listeners. So thank you very much to all the speakers, sir. Mahesh, sir, Sunita madam, Sangeeta ma'am, and Dr. Kumar Rajan, sir. I would like to conclude this webinar with the thought on what we have learned today during this session and how that fits into the overall dental practice. So what we have understand, by this session, that NABH standards are very much effective to prevent any kind of to prevent the outbreaks like COVID-19 or other one, and a good infection control practice can be very helpful for a dental clinic and hospitals. So thank you all. We appreciate you being here, sir, ma'am, and all. Thanks again for joining us today, and we will see you next time. Thank you very much.
Abhishek, I would also Abhishek, I would also like to thank once again. I think this has been a wonderful session, and just for record, we'll be placing a recording on our website also. And after that, the reach, sir, is phenomenal. Actually, we have seen that 4,000 to 5,000 people log in at their time, and these webinars and these words of wisdom have been very well received. And we are very sure that under your guidance, the new technical committee will also formulate, basic standards, so that every dental single clinic, single chair clinics, small clinics to big hospitals, they can enjoy the benefits of accreditation or certification at a very low cost. So we are really very hopeful for the future as far as the dental certification and accreditation standards are there, and really grateful to all of you for sparing your valuable time and expertise for NABH today, sir. Thank you so much, all of you.
Yeah, we thank the NABH to invite us for this panel discussion, Dr. Atul, Dr. Abhishek, and of course, all behind. Yeah, thank you so much.
Thank you, Sangeeta, Sunita, and Kumar Rajan. Thank you.
Thank you, respected seniors. Thank you, and Abhishek. Thank you so much. Thank you.
Thank you.
Thank you, everyone.